Yeah, live kuduthurunga, then we'll live on YouTube.
So now YouTube on live, sir.
Yes, sir. Shall we start? Just start பண்ணிறேன். Sir, Sajan sir is not able to see me.
No, sir. Sajan sir is already shared his screen, sir,
Right.
now.
Yes, okay. I think we'll start.
Yeah.
Sir, very good evening to everyone. So today will be another session on spine, and we have two, I think, the topmost eminent spine surgeons in Chennai we have with us, and we immensely thank them for their time, sir, because it's very difficult to even get an appointment with Sajan sir and Appaji sir, and giving so much of time to us. We are immensely have to thank them. And I hand it over to our Honorable Secretary of TNOA, Dr. P.T. Saravanan, to welcome our speaker and the moderator. Sir, PTS, over to you, PTS.
Good evening to everyone. So, greetings from Tamil Nadu Orthopedic Association. So, welcome you all to the 19th PG teaching program of TNOA. So, today, topic everyone knows, it's cervical spine injuries with the eminent speaker, star speaker, Dr. Sajan K Hegde. So, our moderator of the day is Dr. Appaji Krishnan. So, from tomorrow onwards, from 10th October to 24th October, so we are going to observe TNOA Bone Health Awareness Fortnight. So, to commemorate the International Orthopedic Health Days. So, World Arthritis Day, World Spine Day, World Trauma Day, World Pediatric Bone and Joint Day, and World Osteoporosis Day. So, I request all our members to observe these days as per the theme of our TNOA president. So, as a customary, I introduce our moderator, Dr. Appaji Krishnan. He is a senior most spine surgeon. So, he is, welcome sir, senior most spine surgeon in the SIMS Hospital, Chennai. He is undergraduate and postgraduate from Premier Institute, Jipmer, Pondicherry. He did his DNB and fellowship in spine surgery at Apollo Hospital under Dr. Sajan K Hegde. He is a fellowship in spine surgery at South Korea. He is a AO trauma fellow from Germany. Sir is a very leading spine consultant at Chennai, doing all complex spine surgeries and deformity corrections. So, on behalf of TNOA, I welcome you, sir, Dr. Appaji Krishnan, sir. I welcome Dr. Sajan K Hegde also. I hand over to Dr. Appaji Krishnan to moderate the session and introduce our speaker. Yeah, thank you.
Thank you, Dr. P.T. Saravanan, Secretary TNOA, and Tirunarayanan for the opportunity. It's a great pleasure to introduce Dr. Sajan K Hegde. He is my guru. Most of you will know we have traveled together last 18 years. So it's not easy for me to introduce such a big name. I joined him in 2002, but he was the one to establish spine surgery as a separate specialty in south of India, I'll say. Even before Dr. Rajashekaran of Ganga Hospital came back from UK, that was in 91 or 92. Dr. Sajan was here in 89 at MIOT. He has pioneered introduction of everything what we know of, from the Moss-Miami system to what we call as P-lift, what we call as T-lift, artificial disc replacement, and off late robotic spine surgery. So he's introduced these technologies to this country. As you all said, he's not the leading spine surgeon of Chennai, he's leading spine surgeon of this part of the world, where there are patients traveling from Australia and New Zealand to get operated from him. So without much ado, I'll request Dr. Sajan K Hegde to go ahead and start this. The postgraduates, I'll tell you one thing. All of you should listen to him, and orthopedics surgeons should take more and more spine surgery. So I hope Dr. Sajan could inspire as many of you as he has inspired me. Sir, please go ahead.
Thank you, Appaji. I never looked at it from this angle, that orthopedic surgeons are becoming allergic to spine surgery and especially cervical spine surgery. And I think that's not a good thing. And we do whatever we can to reverse that trend. And from my part, and I think Appaji will agree with me, we are happy to train uh, all the youngsters in these new techniques. I must admit before I start this talk that I'm visiting this topic after a fairly long time. So if I appear rusty, I have requested Appaji to step in and correct me and say, sir, this is what you're saying is a little out of this. Please change it. So Appaji, don't hesitate to interrupt me. So starting from the beginning, how do we? 1 minute, I'll just get it sorted. Why are we not able to move? Okay. So all spinal injuries are extremely devastating, especially because they the most active age group, 20 to 40, and most of them are due to vehicular accidents. We know this pandemic has been the worst thing that could happen to mankind. But one thing that what happened during this pandemic is that vehicular accidents came down to almost negligible limits. Unfortunately, as I see it now on the roads, people are still breaking rules, and this is something it's very important. This mindset to follow rules, to adhere to regulations, it should come into our mind and not travel, for example, on the wrong side of the road and all. So spinal injuries are extremely devastating, and vehicular accidents. The other thing, which may not be so relevant here, but especially in the West, in Europe and other places, it is sports-related injuries. And we know there are risky sports as like the F1 and the other sports where people can meet with all kinds of accidents. So this can lead to extremely severe injuries. The other thing is falls, either from height or falls from like while riding a horse. And we all know about Christopher Reeves, who was Superman before an unfortunate horse riding accident led him to sustain an upper cervical injury. And then he was a tetraplegic after that. But he was always an advocate for all spinal cord injuries. We know that in our rural areas, people climb these trees, the coconut trees, to get the coconuts. And of course, we get a lot of them who fall and injure their spine. And of course, so what is the goals of management in acute spinal trauma? The most important thing, of course, is preservation of life. The next most important thing is preservation of intact neurologic function. These are very important things that all of us understand, because if one is at a site of an accident, this can make a difference between a patient who will walk or who will be paraplegic for the rest of his life. Restoration of spinal stability, prevention of spinal deformity, these of course come later. Treatment of associated injuries, prevention of complications, enhancement of neurological recovery, and facilitation of functional recovery or physiotherapy and other things. Now, it is most important that at the site of trauma, because this can make the difference between a patient surviving or not surviving, surviving with extreme disability, or having a decent way to live his life in future. So treatment starts at the site of injury. One should follow the ATLS, Advanced Trauma Life Support Protocol. The immobilization of the spine or of the patient on supine on a spine board with strapping, Philadelphia collar for neck immobilization are very, very important. What do you do at the site of accident? The most important thing is you take care of the airway. You take care of the breathing. And if the patient is losing blood, then you need to get control of the circulation. You may have to start some drips. Later, of course, you have to look at the disability, at the neurological status, which can be quickly assessed at that time. And of course, you have to make sure some of these injuries are in extreme climates. So patients should be kept in warmers, and that is very, very important. There are some simple algorithms that one can follow. I don't know if you people are familiar with the Canadian C-spine rule. I would strongly recommend that you look at it. This gives you a very simple step-to-step on when you should do, what you should do, when you should do radiography, when you should immobilize with a collar, etc. So it all depends on the assessment after the patient comes into the OR. The neurological assessment is about looking at the neurological deficit. So typically you use the modified Frankel, that is the Asia impairment scale, Asia A being complete and Asia E being normal motor and sensory. The other things that need to happen even at the site of accident is that you may give oxygen. You have to maintain a high SpO2 at 100%. Now, we will talk also about methylprednisolone and other things. Now, this has been a huge controversy. There are a lot of senior surgeons who believe that steroids have no role to play. But I have heard, for example, from the Canadian group, and they have used steroids, and they have found that at least it helps in preventing worsening, and it helps in mitigating the ongoing pathological consequences of the injury. So, which we will touch upon in a brief way. So typically we follow the NASCIS-3, that is an initial bolus of 30 milligram per kilogram in the first hour and a continuous infusion of 5.4 milligram per kilogram per hour for 24 hours. So this is something that all of us do, but some of us may not agree with the use of steroids. When the patient comes, the first thing you do is get the x-rays. Obviously, you have made an assessment, you looked at the possibility of other injuries, and now you can get the radiographs done in a very quick manner. And you do these x-rays, whether to go for the CT scan first or MRI, that depends on individual choice. But in a spinal injury, my personal preference is first for a CT scan and then an MRI. I prefer to have all these investigations before I start on my decision making. When we talk about spinal injuries, there is the injury to the spinal cord, and then there is injury to the vertebral column. And the pathophysiology of the spinal cord injury is that initially, immediately there is hemorrhage, contusion, and ischemia. And in 3 to 8 hours, the edema and inflammation sets in, and there is increased liberation of the tumor necrosis factor alpha. Delayed changes are ischemia, which can spread above the level of the injury, and myelomalacia, syringomyelia, which develop in the long term. The injury can be a complete injury, that is transaction, physical transaction, or it could be ischemia, which is almost like the transaction. That means there is no neurological function distal to the level of injury. Incomplete, you can have a Brown-Séquard syndrome, that is like a hemisection. The prognosis is normally very good in this case. You can have a central cord syndrome, which is typically seen in elderly extension injuries, where there is when they have pre-existing stenosis, and the prognosis is often very good. Anterior cord syndrome is when there is a flexion compression injury. The prognosis in such situations is poor. Posterior cord syndromes are very rare. And of course, this is only about the cervical spine, so we don't have to talk about the conus injuries. The vertebral column injury is the bony injury and the ligamentous injury. And of course, it depends on the mechanism and the velocity of injury. So what is important to understand is the instability, which causes repeated cord injury. The instability causes repeated cord injury after the initial insult at the site of accident. Compression, which causes a constant compression on the cord and prevents recovery of the cord. So these are important things that one has to understand that go into the decision making when we decide when to decompress, when to stabilize, and why we do that. There are numerous classifications, mostly based on the mode of injury, that is a mechanistic classification, or the type of fracture, that is morphology, or on instability. Surgical management indications are incomplete neurological injury, instability to prevent deformity where the neurology is intact. When do you operate? Do you operate immediately within hours of getting the patient? Do you stabilize the patient and then operate? So all this has been controversial. My take on this is that I like to have the patient stable. I will not operate in the middle of the night if I feel that will compromise the quality of surgery that I do. I would rather wait for the morning when the entire staff is available. So I prefer to wait, and I do not feel one loses out a lot in waiting for a little while. However, early, that is less than 72 hours, is better than later, that is later than 5 days. So the positives of operating early is that you prevent the secondary pathological changes. Of course, when you operate very early, sometimes the patient may not be entirely fit. So ideally, you have to decide, get the patient as fit as possible, whether he can undertake the surgery, and then go ahead and do the surgery. Let us look at different injuries at different levels. Coming from the top, the craniocervical junction, you have the occipitocervical junction and the atlantoaxial complex. Functionally and anatomically, they are very different from the subaxial spine. And the injuries of the upper cervical spine have a bimodal prevalence. That is, you have very young children who are often children in high velocity accidents in cars, or you have very old people who have sustained minor trauma, and after a minor fall, they have these upper cervical injuries. Early detection and treatment is very important because that will reduce the mortality and your outcomes will be better. Now we have better internal fixation devices, and of course we have very good rehabilitation, so the outcomes are very good. Occipitocondyle fractures, one of the most elusive causes of neck pain. Sometimes a patient would have been in a car accident, continues to complain of base of the neck, base of the skull pain, and one may wonder where it is coming from. And if you go deeper into the history, you may find that he had sustained an injury, and then you would have to do studies of CT scan to understand if there are any injuries. These are high energy trauma to the head and neck. The rate of mortality is very high. You have to have a high index of suspicion. So patients presenting with pain, torticollis, headache, impaired mobility, you should immediately start thinking whether there are occipital condyle fractures. X-rays may often be normal. So you should do the CT scan, which is the best modality for diagnosis. There are different classifications. We won't go into the details. You can read about it. Atlanto-occipital injuries are again high-speed injuries. When you do an X-ray, you may see a soft tissue swelling at the C3 level. And again, there is a classification that is the type 1, type 2, and type 3. The type 1 is the anterior displacement of the occiput on the atlas. The treatment could be a halo. The type 2 is the result of longitudinal distraction. In such a situation, you should not use traction. You should reduce and do occipital-cervical fixation. Type 3, of course, occipital-cervical fixation is the way to go. So here you can see a typical C0, C1 fracture with an associated C4, C5 burst fracture. The C0, C1 was treated conservatively, and the C4-5 burst fracture was treated with surgery, with corpectomy and reconstruction. Coming to the fractures of the atlas, it was first described by Jefferson, often complicated by craniofacial trauma. So when you have a patient from a high velocity vehicular accident, patient has craniofacial trauma, always think of and rule out the fractures of the atlas. Hyperextension axial loading is the typical mechanism of injury, motor vehicular accidents, falls, and sports injuries. Isolated fractures of the atlas, usually there is no deficit. Again, they are classified into type 1, type 2, and type 3. And majority of atlas fractures can be treated non-operatively. Of the orthoid is again due to motor vehicle, or they can do low injury in very one of the hip. This does not require any surgery. You just give a collar. Type 2 is a mid-waist fracture. These never heal, high incidence of non-union, and you have to reduce and fix. Type 3 is extending to the body of the C2. Some of them can be treated with cervical orthosis. Odontoid fracture with C1, C2 subluxation. Here you can see, and you can see the changes in the cord. This is because of the repeated injury. And this has been treated with a C1, C2 transarticular fixation. And this allows the patient to have immediate mobility and get back to normal. Fractures of the axis, again, are due to motor vehicular accidents, judicial hangings. We are now familiar with the day-to-day during the pandemic about Sushant Singh Rajput. In all probability, he had fracture of the axis, which he sustained due to the suicidal hanging. This can also be due to judicial hanging. And typically there is spondylolisthesis of the axis. The type 1, there is a fracture of the pars. Type 2, there is fracture of the pars with more than 3 millimeter translation. Type 2A is fracture without translation and angulation. And type 3 is fracture with unilateral or bilateral facet dislocation. So while the type 1 and type 1 can be treated with rigid collar, type 2 with halo, type 3 would almost always need open reduction and internal fixation. Here you see a fracture of the axis type. Now see what I did by mistake. I applied too much traction and quickly realized that this is not something I should do. This was, of course, done way before good posterior implants were designed. In those early days, we were using wires. So an anterior surgery was done with a bone graft, tricortical bone graft, and without, of course, a excessive distraction. And then a posterior tension band was applied with the wires. So this was done many, many years ago. But the lesson one has to learn is one should never have this kind of picture. This is extremely deleterious to spinal cord function. Coming to the subaxial spine, in the early days, we had Allen and Ferguson classification for cervical spinal injuries. It was compressive, destructive, or vertical compression, or lateral compression. Also, there were McAfee and Frankel. But of course, now most of the youngsters would be familiar with the AO classification for the upper cervical spine, and AO classification for the subaxial spine. It is better to carry this chart in your pocket whenever you are dealing with a cervical spine injury. You should always be able to put what category it belongs to, if only so that it helps in your follow-up when you're doing an academic study. So here you have bifacetal. We'll look at a few injuries. Bifacetal fracture dislocation. This patient has a paraplegia, the 6/7. Now, typically when you have a 6/7, the patient's breathing is not affected. And the patient's, the prognosis, at least for life, is much better than an upper cervical injury. So how would you handle it? It is a flexion distraction injury, and you want to first reduce it. So you do a simultaneous front and back, because it's a 3-column injury. So you have to address it from the front. So you put the patient on traction, on tongs, reduce the fracture, make sure the fracture is reduced. You may have to wait for a day or two before it falls in place. Usually it does. And then you do an anterior surgery, and then you do a posterior monosegmental fixation. So this is the ideal way to do it. A flexion distraction injury, 2-month-old injury, the patient is neurologically intact. Look at how beautifully you can see, the C3-4 dislocated left facet joint. Look at this, how it has jumped over the facet. And you can see how the right side, the C3-4 is just subluxed. There is a partial facet dislocation. And look at the x-rays. So typically you see this. The patient may have a rotational malalignment. So he may present like with the torticollis, but with pain. And this patient came to us 2 months after the injury. So how do you treat it? Some people would say, do from the front. You can never do these injuries, especially when they're old, from the front first. You have to reduce the facets from the back. You cannot also reduce it. You cannot do a close reduction. So we do the backs first, realign the facets, correct the alignment, fix it monosegmentally. I do not like to fix multiple levels. And then you turn the patient for an anterior surgery. And you can see it is beautifully reduced. A flexion distraction injury, C4/C5 with quadriplegia. You put traction, you reduce it, and do a front first, then you go to the back, and then you correct it. This patient had a diving injury. He was quadriplegic with bladder involvement. You can see it is only involving the disc. It's only a soft tissue injury. So in this case, you can just remove the disc. You do not have to do any corpectomy. You just put a graft or a spacer, and then you fix it. So you do an anterior discectomy and fusion. At 1 year follow-up, the patient has significant, he is Asia D, so he has improved considerably. This is a flexion injury with subluxation and facet fracture. You have to understand, this is why the CT scan is very important. You can see a pars fracture of C7. You can see a C6-7 subluxation. This is very important. And then you see the forward listhesis of the vertebra, above vertebra on the below one. So this is due to a road traffic accident. The patient has no deficit. You see in the CT scan also the fracture at the level in the posterior element. All these things are very important in your decision making. So you know that the injury is all in the back. Anteriorly, it is more or less clean. The discs are not damaged. So you can get away with the posterior alone surgery in this case. Here you have a flexion compression injury with vertical fracture lines in 2 vertebrae. You can see this fracture line running. This is the displaced fragment. And you can see there is already edema in the cord, severe compression. What would you do? You have to do a corpectomy. So you do an anterior surgery, you do a corpectomy, and you reconstruct with a cage. And you do an anterior stabilization. At 1 year follow-up, the patient has improved considerably, and he is Asia D. So these decompressions, reconstructions always help. You cannot say that cervical spine injuries can be just left. This is a very interesting case. This is the case of a leading general surgeon who owns a leading hospital in Chennai. He was sitting on a swing with his granddaughter. I can also mention the name because Dr. CMK Reddy is a very good friend of mine. Professor CMK Reddy, who has the Halstead Clinic, was sitting on a swing and he fell down backward, hit his head on the floor, on the ground. After the injury, he complained of severe pain in the neck and severe radiation into the shoulder. They did an MRI. They did not find anything wrong. When he came to me after almost 6 to 8 weeks, we thought there was something else that had been missed. So we did a CT scan, and you can see here, beautifully outlined, the unifacetal dislocation of the, what is this? 2, 3, 4, 5, 6. And this was done 15 years back. We did a reduction from the back, and then we turned him over for the anterior surgery. Professor CMK Reddy has been very active, doing FRCS exams, doing his practice. He has been absolutely normal. Here we have a 53-year-old male who met with a road traffic accident, had polytrauma. You can see multiple injuries. And you see he has a type 2 odontoid. How will you fix it? So typically, you have to reduce it. This is the MRI. The patient was neurologically intact. So we close, reduce, and do an internal fixation. Now, what do I want to show you here? You have to use 2 image intensifiers. You get the lateral and you get the AP, and you just make a small incision at the C4-5 level to get to the space to put the screw. And then you have reduced the fracture, close, reduce the fracture, and then you fix the odontoid. And this is after, I think it's a follow-up, and you can see the fracture is healing very well. Anbalagan is 43 years old, road traffic accident, quadriplegia below C5, Asia A, treated with skull tongs. He also had a comminuted fracture. You can see the dislocation. So typically, how would you treat it? So you put on tongs, you close, reduce, and if it does not reduce, then you have to do the posterior first. But if it reduces, you can do the anterior first, and then a posterior stabilization as well. And at 8 months follow-up, he has a good healing. Bada Hamoud he's a 24-year-old who came to us from Oman, a unifacetal dislocation. You can see here the dislocation. And here you have to appreciate the fracture in the spinous process. But most important, the perched facet. This is a classical sign of a unifacetal dislocation. There is also associated spinous process and a laminar fracture. And again, a back front is the way to go. Bharti, 57-year-old gentleman, had fractures mostly in the posterior elements. Here you see the fractures, fracture of the pars C7. Anterior, you see it's quite okay. He is neurologically intact. The discs seem to be good. So you just do a posterior stabilization, monosegmental, and you get away with it. This again, Shifat bin Ali, he came to us, 19-year-old from Oman, unusual injuries. So he had a fracture, slip over one over the other, and also an associated odontoid fracture. So there were two of them. So when we decide what to do, we do the MRI to see if there was any disc protrusion. Then we do it from the back first. So here we did first the fixation of the odontoid and then put him prone for the posterior fixation and reduction of the lower fracture. Here you have a 63-year-old male who fell and hurt his back. He came with complaints of severe neck pain. His neck movements were severely restricted. This I already shown, sorry. This is Dr. CM K Reddy. I will quickly follow that. So this is Professor CMK saying, greetings, it is 15 years since I got operated, that I've been totally asymptomatic since then. This is the patient who came with the history of fall 2 months back. She came to us from Mauritius. This is the fracture dislocation you see here. Again, you have to appreciate the dislocation at one side and the subluxation at the other. You can never correct them from the back. You have to do, corrected them from the front. So you have to do posterior reduction and stabilization and anterior reconstruction. So I think this is enough. So when there is a discal injury, you do it only from the front and the patient goes on to improve. This is the patient. Yeah, this patient came with upper cervical injury, a detailed assessment. We showed us the fracture of the odontoid. Now it is debatable whether this is actually going on to be a type 3. So whether one should fix it or whether one should leave it. We fixed it with 2 screws closed reduction. That's all I think. I will quickly skip. One minute. Now, when you have an injury like this, again, you have to do it. It's mainly a discal injury. You have to do it from, you can do it, but 1 minute. This is an injury. You can see the injury is in the posterior structures, but the disc, though there may be injury, it is not disrupted significantly. So what I wanted to show here was that you can sometimes get away with a posterior alone surgery. Here you have you have the injury you can see the changes in the posterior structures. But here we have decided to do from the front. Why? Because the patient had myelomelistic changes and discs resting on the cord. So we decided to do the discectomy and reconstruction. And at 1 year follow-up, he is beautifully healed. So this is again a patient met with a bull injury and front and back. So before I end, I want to show you that cervical spine injury is one of the easiest surgeries to do. But when done by a poorly trained surgeon, you can have a lot of morbidity and maybe even lead to mortality. This patient was a 54-year-old unfortunate gentleman who had a traumatic cervical spine injury, C5-6, with quadriplegia. He was Asia A. He underwent anterior and posterior. I don't know why he needed all of that. Anyway, he was operated C4 to C6 fixation. The surgery was done in 2 stages, anterior fixation followed by posterior 3 days later. Post-surgery, patient was in ICU for 3 months. Tracheostomy was done. In ICU, he developed surgical site infection. 5 months later, he developed a right pharyngocutaneous fistula. Now, when he came to us, he had a discharging sinus at the right lateral aspect of the neck. And we did all the scans. We had nothing from the old scans, and we found some fixation done like this. And we found that he had an esophageal injury. This is, you can see the saliva coming out. This is the tube in situ. So we operated on him to close and assess the esophagus. This is the tract, sinus tract, which was removed. This is the pus that was collected. And here you can see we injected some dye to show the esophageal tear, and we could demonstrate. See, look at the fluid coming out. That is the esophageal tear. So if you do not take care and do not do these surgeries carefully, and the
your voice is breaking.
Spinal injuries are the
I think
sir, knowledge of anatomy.
Sir, your voice is breaking. Can you go through that slide again? Yeah, there is some issue with the connection.
1 minute. Yeah. Can you just connect it? Are we okay now?
Yeah, now it's fine. Now it's fine. Yes, sir.
So it was just a conclusion, Paji. Spinal injuries are devastating injuries. Management requires utmost care. Sound knowledge of anatomy, mechanism of injury is a must. Surgery in a spinal injury is an important part of the management, and rehabilitation plays a major role in getting the patient back to near functional level. Thank you.
Thank you, sir. Thank you very much. It was indeed a learning experience. I think most of the PGs are wondering. There are some questions, sir. The main question is kindly elaborate on Canadian spine rules. So can Vignesh present on Canadian spine rule?
Who knows? You know, you? Yeah, you can.
Yeah, Kayur is a ASSI spine fellow at Apollo Hospitals. So let him elaborate on the Canadian spine rule. Yeah, Kayur, go ahead.
Yes, sir.
You put that.
Yes, sir.
Put that slide, the 3rd or 4th slide, I think.
Yes, sir.
Yeah. Ramesh, can you allow Kayur to share slides again?
Yes, sir. This is the.
He can.
Yeah, share your screen, Kayur. Your screen is off now. Yeah.
Just click. Yeah, that's correct.
Yeah.
So this is the Canadian spine rule. See, cervical spine rule is basically for the first assessment in an ER room. So whenever a patient with any of the high risk factors, as in a patient who is more than 65 years old, or had a very severe mechanism of injury, or has a neurological deficit, then you have to directly go for a radiography. Basically, X-ray, MRI, CT, you have to go in sequence. If any of this is not there on your primary assessment, then you have to assess any of the low risk factors which allows safe range of motion. So if the collision was not that much severe, or the patient is in the emergency department, is in a sitting position, or is ambulatory, or has delayed onset of neck pain, or has an absence of midline neck pain, if none of these are there, then you have to go for radiography, or he is able to do all these things. He is sitting in, or he is ambulatory, or the way accident was not that severe, then you have to check the movement of the rotatory movement of the neck. If he is able to do, then you don't have to do a radiography, or else if he is not able, if there is a severe restriction of movement of the neck, then you have to undergo a radiography. And the rule is not applicable in non-traumatic cases, or if the Glasgow scale is less than 15, or the vital signs are not stable, age is less than 16 years old, if there is acute paralysis, if there is a non-vertebral disease, and previous cervical spine injuries, or pregnant.
Yeah.
And
so the Canadian spine rule is for patients with neck injury and intact neurology, and not in any disorientation like coma. GCA should be 15/15, and patients should have intact neurology, right? KU?
Yes, sir.
Yeah. So the next question is the role of IL-6 and GM1 gangliosidosis. I think I will only answer that question.
Yeah, Appaji, you answer.
Yeah, so IL-6 is interleukin 6 and interleukin 6. I mean, most of us will be aware now with the COVID, which is an inflammatory marker, and GM1 gangliosidosis also. They are nerve injury markers. If they are very high, the outcome, they are prognosticating factors like IL-6 and GM1 gangliosidosis are very high, then you have very poor prognosis or outcome of neurology. The second thing is there are some drugs which we are now, they are being given also in motor neuron disease, especially amyotrophic lateral sclerosis, that is ALS, that is called Riluzole. Riluzole is a drug which has been studied extensively in the Canadian Spine Society, and that is an anti-GM1 ganglioside agent that is to prevent the neurological injury. So IL-6 and the role of IL-6 and this thing is the inflammatory markers to rule out, to prognosticate the outcome in a patient with cervical spine injury. The next question from Thiru is about stem cells in spinal cord injury. So, sir, you will tell, or I will only talk
Appaji,
about?
You clear the air.
Yeah. So, as Association of Spine Surgeons of India Executive Committee member and a long-serving spine surgeon, we are against use of stem cells as a treatment option in any cord injury. There are treatment. There's no treatment as such which is now approved by any society or any governmental agent for spinal cord injury in using stem cell therapy. Stem cell therapy is now in an experimental status. So if people want to do stem cell therapy, they should register themselves with ICMR in India. There is a stem cell registry where you can do and last but not the least, these patients should not be charged. So we have, I've been part of one of the outcome studies in ISIC, that is the Indian Spinal Injury Center, where we used the neuroglial stem cell from the olfactory neurons, and the outcome has not been very great till now. And there has been no patient reported in any spine journal or a neurosurgery journal telling that they have improved purely because of stem cell therapy. So there is no report of any patient improving. So stem cell therapy as a treatment is no. Stem cell therapy as an experiment is still allowed, provided you are registered with ICMR. Yeah. So Vignesh, can you tell these people on the Asia scoring?
Yes.
Yes, that's another thing which all the PG should know. Asia scoring is a short question. So yeah, Vignesh is another, he's a qualified spine fellow now. He's finished a year ago his ASSI fellowship at Apollo Hospitals, and he's presented in very prestigious conferences also.
Yeah, go ahead.
Spinal cord. Yes. So ASIA A is complete injury. That means there is absolutely no sensation as well as motor power below the level of injury.
Yeah,
And,
yeah.
I think you
Vignesh,
all know.
Vignesh, first tell them what is Asia. Yeah.
Okay, sir. American Spinal Impairment Injury Score.
Injury assessment score.
Injury assessment score, where Asia A, that is American Spinal Injury Assessment Score A, would mean that it is a complete spinal cord injury, where below the level of the cord injury, there is no sensation and no motor power, including the bladder and bowel, which is completely paralyzed. I hope that we all know that the vertebral level and spinal cord levels are different from cervical to the thoracic, lower thoracic region, where we will have to, in cervical level, it is equal to the, like, is C3, the cord level is C3, but at D12, the cord level would be lumbar levels, all the 5 lumbar levels. Asia B would be incomplete sensory and complete motor. There will be some sensations left, even maybe the bowel and bladder might be intact. The sensation, the catheter tug or the bladder sensations might be intact in Asia B, but the motor power is 0 below the level of cord injury. Asia C, there is power, there is motor power which is less than grade 3, MRC grading. MRC grading of less than grade 3, which is against gravity movements is not possible, but there is some movements in the lower limbs with more than 50% of the muscle groups. And Asia D would be more than 50% of the muscle group below the level of injury, which has more than grade 3 power, which we consider as spine surgeons in rehabilitation to be useful power for rehabilitation, which is more than grade 3, which is movement against gravity in more than 50% of the muscle group. Asia is normal neurology. Appaji sir. Hello sir.
Appaji is muted. Huh?
Appaji sir, you are muted, sir.
He cannot.
No, they are muted.
Appaji sir.
You stop the screen sharing and open that and see who is supposed to put a message there.
Hello.
Sir.
Yeah,
sir, I just finished. We could not hear.
Yeah, sorry, I was not muted. I was muted, so I didn't unmute myself. So for all practical purposes, Asia D is a functionally intact individual. They may be independently walking. Asia is normal motor. Asia C, they may have some root preservation or some motor preservation below the level of injury. Asia A and B are mostly invalid below the level of injury. So that is the other question which was asked. And robotic, yeah. Okay. Somebody has asked if we can remove the cervical collar when a cervical spine injury is suspected to do a secondary survey. Cervical collar can be removed provided it is done under supervision by the surgeon himself or by the orthopedic or orthopedic surgeon present in the emergency, and you prevent movement of the neck, that you give sandbags or water bottles on the side and make the patient totally immobile. You can still remove the collar, but most often maintain it till you get the entire screening done by radiology. The next question is, GL6. Asia Empowerment we finished, Canadian Spine Rule we finished. Okay. So to summarize what sir has presented, so cervical spine injury, most often I see orthopedic surgeons referring most of these patients to neurosurgeons, which I somehow I feel ashamed sometimes that they should not do it. Cervical spine injury is divided into two parts. One is the craniocervical, upper cervical injury, or the subaxial spine injury. So C1, C2 is a completely different ball game. Previously, people used to fix occipitocervical for most of these. Now the newer, as sir has shown, newer fixations which give you options of repairing the fractures in situ also, like odontoid screws, C2 par screws, or C1, C2 fixation for a subluxation. The subaxial injury, subaxial spine injury, the classification is by AO. Most of it is available in the books. You can go through them. There is also a cervical called cervical spine injury scoring system which is being developed, which is also equal to almost the AO, and both are same. It includes neurological deficit. The other important thing about subaxial cervical spine injury, a neglected cervical spine injury, is white Punjabi criteria to rule out subluxation and the instability. As sir has pointed out, most of the time you'll see an angulation only in there won't be a neurodeficit, but you will see an angulation between upper body and the lower body. The criteria are a 3 millimeter translation anteriorly, 11-degree kyphosis segmentally, and rotatory instability. So white Punjabi classification, you people should all read about instability scoring of white Punjabi. So if the score is more than 3 or 4, there are different scores, 0, 1, 2 for each, like the angulation, translation, and also the rotatory instability. So if you have a score more, so these are patients which require surgery again. The third one is most important is the secondary injury, which sir also stressed upon. It is about evacuation of the patient. The treatment of cervical spine injury patient starts from the site of injury. More importantly, prevention of secondary injuries and instability during evacuation and transport, evaluation and surgery, all through. If you have a subluxed spine with a neurologically intact, it'll be criminal if the patient becomes quadriplegic while transporting or while in the hospital. So we should all be very, very careful. So the transport people should be very, very careful about how to handle these patients, and very knowledge about doing the splinting of cervical spine. And the second thing is, in the hospital, a quick survey is very, very important. Most of the hospitals now, bigger hospitals, have a quick spine survey. Possible they do a run through in 2 minutes about the entire spine. So it's easy to evaluate. But most importantly, ATLS. So in the emergency, all of you, I think PGs will be posted in emergency. ATLS is a must. So airway, circulation, breathing, and hemodynamics, then the neurological score in these patients. Then you go for radiological evaluation. Surgery wise, as you'd have all seen, it requires training. As sir said, you cannot be a poor surgeon. You are a poor surgeon once you are not trained. Spine surgery is not difficult. You should get to people who do surgery. There are now almost 20 FNB spine surgery seats and 20 ASSI spine surgery seats available as fellowship all over the country. So I think you people should go ahead and get trained. And once you get trained, I think it'll be like any other surgery. You'll not be afraid to do. Most important other thing in cervical spine injury is the vertebral artery injury. Sir mentioned in one of the slides. So vertebral artery injury, you should, if the patients may come with a posterior brain strokes. If there is a vertebral artery injury, so you should also know about the vertebral artery anatomy. So it enters a cervical transverse foramen at around C6 and gets out at C2, and then makes a turn around the C1 arch and then enters the foramen magnum. So while exposing posteriorly at the upper C1, C2 junction, like sir showed a transarticular fracture, a transarticular screw fixation, or the Magel screw fixation for a C1, C2 subluxation, or a fractured C1. In those situations, you should be very careful exposing the vertebral artery, and you should be aware of it. So these are, I think for PGs, I think this should be more than enough. Dr. Thiru or Dr. P.T. Saranan, if you are there. Hello. Please unmute yourself,
Sir,
Dr.
yes,
Thiru.
yes. Sir, I'm here, sir. I'm here, sir.
Yeah.
So I am here, sir. So are we completing the session, sir?
Covered almost, as far as PGs are concerned, the questions which I've often seen, you don't get a practical patient of a cervical spine injury,
Yes,
because they
yes.
are all bad patients. But in theory, these are 5 important questions. One is white Punjabi, second one is Asia impairment, third one is the classification of cervical spine injuries. The subaxial spine is a separate classification, and the upper cervical is a separate, Odontoid, C1, C2 is a separate classification. And the role of steroids, as Sir has actually talked well about the North American Spinal Cord Injury Society trial of steroids. Even though most of us say we do not have a legal standing still against the steroids, but most of the senior spine surgeons have stopped using high dose steroids because there are more complications due to steroid and less benefit. But still, the Canadian Spine Society talks about usage, so people should know about the dosage and when to give. So if the patient comes less than 8 hours to the hospital, they have shown that there is a increased benefit. That's only from that group which studied the NASIS, which published NASIS. But outside of that, most of us are very skeptical about using steroids. The second thing is about stem cell therapy. So as I said, stem cell therapy is experimental, and we have not been able to produce a functional neuron using a stem cell inside the body. We are able to grow the functional neuron in vitro, but in vivo they all form glial cells, not a neuron cell. What else should I be talking about? I think that covers almost entire spine injuries.
The gamut of spine injuries has been covered, sir, cervical spine injuries.
Yeah.
So on behalf of TNOA, we immensely thank you, sir. I know we have interacted with a legend and a legend to be in spine, sir. And of course, the inspiration to the PGs is to take up spine surgery and become eminent like Dr. Appaji and Dr. Sajan. And definitely, I think the message has been conveyed very clearly, sir. It's not only about the subject, and also the importance of spine, to learn spine injuries and about spine surgery. I think PGs will definitely take. So my one simple question, normal question is, so when can you suggest the postgraduates to go in for a spine fellowship, or how early in their career do you advise them to take up spine as a separate specialty?
Yeah, I feel spine, if you see Campbell, half of one of the volume is spine surgery, right? Yes, I think volume 3 is completely spine surgery. So I think it should be part of their training in MS itself. And then after 1 year of post-PG, they should choose arthroplasty or whatever they are interested in. And spine surgery is one good field which they can consider.
No, my question is when they should consider it, sir. You mean immediately after 1 year?
1 or 2 years down, when they are good enough to know the importance of subspecialization. So yes, most of us do not want to subspecialize. Some of us want to subspecialize, want to learn more, because spine surgery is also very vast. It is from deformity, low back, degenerative. Spine surgery is not very small. It's not trauma alone. So every orthopedic surgeon should know about trauma and the trauma care of spine. But deformity, degenerative, and pediatric spine, I think they should go for a fellowship if they are interested, maybe 1 or 2 years down the line. Yes.
So how difficult is the road to a top spine surgeon, sir, when compared to arthroplasty surgeon or a trauma surgeon? So how difficult is the road to be traveled, sir? It's very easy, or it's I know it's difficult. So how difficult it is when compared? I think Sajan, sir, I think.
Dr. Sajan can answer that question. I've had it very easy, so
maybe you had Sajan sir with you, sir. Not everybody is going to get that opportunity. So
I think the message that I would like to give to the youngsters is,
Yes, sir.
they should be focused, motivated, and eager to learn.
Yes.
They should not be afraid to ask questions. They should be good observers.
Okay.
Should observe. They should not repeat the same mistake more than one or two times.
Yes.
They should learn. They should always keep themselves abreast. They should, importance of observing, of learning how senior surgeons move, their body language in the OR, how everything goes to make a a surgeon.
Yes.
Everything. So it starts from even learning how a senior interacts with the patient, how much does he tell the patient, and everything. So it's a very big and long learning process. It is not. I don't know why Appaji says it's easy. It is not that easy.
Okay.
And I think it is. There are ups and downs, and of course, after this unfortunate incident in Kerala, I want
Yes,
to tell all youngsters that ups and downs will come, but life is far more precious, and one should. I feel terrible about that youngster who was driven by this terrible media and everything. So the people should be very strong mentally. People should be very strong mentally, and of course, one should not make terrible errors and things like that. One should be very careful.
I'll tell you something. Actually, when Dr. Rajshekaran or Dr. Sajan Shekhar Boja, they all started. They had to go out of the country to learn spine surgery, come back, start units against lots of odds, and then. But why I said easy is it's now available. There are enough trained spine surgeons in the country. So you choose one of your mentors. Please go and approach. Never be afraid to ask for help. Go and approach a spine surgeon if you are interested, if you are keen to learn. So that is how it should be. That's why I said easy, because I never went out to learn spine surgery. I learned it in India itself, and I can proudly say I'm as good as anybody else in the world because I trained with Dr. Sajan. Yeah.
Sir, and about the robotic surgery, sir, I think Sajan sir is one of the pioneers in almost every aspect of spine that we have mentioned. So he has been pioneer in introducing everything to our country. So what is the present role of robotics? How well it has been taken up, or what is the cost involved for as a patient, sir? So I just want to know from
So I will just give an analogy. So when MRI started in 1990, people said, why do you require an MRI? Why do you require an anatomical diagnosis? Yes. You fellows are all becoming non-clinicians. You cannot palpate. You cannot. Now an ultrasound or a CT scan, MRI is as important like anything else. So robotic spine in robot in urology or gastro, when it started, people started questioning why robot when we can do laparoscopy, when we can do open. But now robotic urology surgery or robotic. So in that way, spine robot as actually now it's a third generation robot. It's not the first generation robot. What Dr. Sajan has in Apollo is the third generation robot. So what I trained with him was the second generation robot. There is a role. I think it has a good future because it gives you immense confidence to do spine surgery, minimal access surgery, very grotesque deformities to negotiate. And if you can prevent complications, because for a patient, a neurological deficit is 100% devastating. So if you can prevent that complication in a patient using a device, why not take it up? Sir can elaborate on that. Yeah.
Yes, sir. Yes.
So it is like this. Recently, I was with the who's who of spine surgery of the world, and we were talking about at the SRS webinar, worldwide conference, which was held online, and some of the biggest American surgeons were saying that I don't mind flying on a plane which is piloted by a good pilot, which is piloted by a good pilot with 25 years of experience, but who can handle a plane. But we know today that all of us would like to fly which are by wire. A pilot just had to make sure that us are working.
So your voice is breaking, sir. I'm not able to hear you.
So your voice is broken again. Yeah.
Yeah.
Your voice is breaking. Yeah. Now it's fine. Now it's fine. Yeah.
Yeah. So which one of us would say we would fly on one of those old? Is it unstable again?
No, it's better, sir. It's better.
So,
no, it's okay.
Yeah. So I think innovation and innovation is inevitable, and I am happy to keep at the forefront of that. I think all the younger generation that are coming, we will be exposed more and more to such new techniques, and they will have to accept it.
Yes, sir.
Yeah, Dr. Thanapan wanted Dr. Sir to talk about the same thing. So I think he got his answer. Yeah.
Yes, on behalf of Thanapan only, I just wanted to ask that question, sir.
Yeah. I also wanted to ask him at the end, actually, because robot is something which is a technology for PGs. Yes, they should know that there is a technology, but to adopt it. But I do not know whether there can be a question for them in the exam, but they should know about it. Yes.
Yes.
How can they ask these questions, Appaji, when the teacher, when the professor himself may not be familiar with it?
Definitely, sir. Definitely not.
We'll have to wait for some time. We'll have to wait for some time. I think there is still some time to go.
Yeah, for it. Yeah, that's what I also felt. Yes.
Yeah.
Finishes early. So our apologies on that, sir. So keeping you in your office for late hours, and of course your assistants and associates are also held up because of you. And so once again, thank you, sir, for having enlightened us on such a difficult topic. It's not a very common, oftenly taken subject, sir. So that's why we wanted a person like Sajan sir on a difficult topic. So and also we want the PGs to get inspired out of an orthopedician being a 360-degree spine surgeon and also getting updated into the topmost and the very recent technology. So thank you, sir, and also thank Dr. Appaji for having moderated wonderfully and bringing out all the points with the postgraduates have to know. So thank you, sir. Thank you once again on behalf of TNOA, and also thank the postgraduates for the patient listening. And my colleague Dr. Thanapan and Dr. PTS of TNOA, and of course the Alembic company who have been behind us and the technological support. So thank you once again, sir. And we look forward to meeting you and very often also, sir. So
thank you,
sir. Thank you very much, sir. Thank you.
Thank Dr. Thiru and others from TNOA for the opportunity. I think all of you had a good time.
Yes, sir. Sure. Wonderful,
good night.
Time,
yeah.
Sir. So thank you, sir. Thank you so much.
Good night.
Yeah. Good night.